Okay. Good evening, ladies and gentlemen. Welcome to our second public forum for the Goodman Cancer Research Center. As you may remember from the last time, if you were here, the series this year is Understanding Cancer Research and Current Treatments, Empowerment Through Knowledge. Et en français, Comprendre la recherche et les traitements actuels du cancer, le savoir au service des patients. My name is Nicole Beauchemin. I'm the facilitator for this session. I am a member of the Goodman Cancer Research Center and a professor in a few departments in this university. Tonight we have prepared something a little special, a little different than what we've been doing for most of our sessions. We were very much wondering at one point, as cancer researchers, and what about pain in cancer? If you have been unfortunate to have to go through the number of treatments for the disease, or if you're a family member, if there's one thing that we all know is as soon as you get the diagnosis of cancer, the one thing you're very much afraid of is the pain. It's also one of the last things you actually talk about. You're not sure. You wonder if you're going to be able to overpower this feeling of fear. You're not actually sure what you're getting into, what the treatments will be, which treatments will cause most pain. And then there's this psychological pain of uncertainty, standing on one foot, never knowing how you're going to come out of this ordeal. So we decided to explore this with some experts. The three speakers that we have for you tonight are specialists in pain. And they'll scan a spectrum of thoughts related to pain, most of which will be related to cancer pain or cancer-associated pain. As most of you know, one of the ways we like to question these experts afterwards, you were given some cue cards as you registered. And if you have some questions, we ask that you fill out the cue cards, and some volunteers will be bringing the cue cards at the end of the presentations to me, and we will address the questions to our experts. If you are excited about a topic and you forget to write down on the cue cards and you ask the question, we'll ask the speakers to repeat the questions, because as you see from my friend facing me, we're taping tonight. If the question is asked by the public, it's not necessarily overheard by the microphone. So the speakers will repeat the question and answer the question as they see fit. So the topic of tonight, as I said, is cancer pain management, understanding pain, new avenues, and support system. Our first speaker is Dr. Yoram Shear, and he will talk to us about cancer pain, a unique entity. Dr. Shear is definitely an expert. He's a professor of anesthesia and the Edwards Chair in Clinical Pain here at McGill University. He's also the director of the Allen Edwards Pain Management Unit at the McGill University Health Center, that big colored building somewhere in between this maze of orange cones. Eventually they'll go away, they say. I think that's part of our pain. Dr. Shear divides his time between caring for patients with cancerous or non-cancerous pain, doing clinical pain research focusing mainly on the role of opioids in pain patients and the analgesic properties of dietary ingredients and pain education to healthcare providers and the public. So please welcome with me Dr. Yoram Shear.
Thank you very much. Good evening. Thanks. Can you hear me? It's okay? Thanks for the invitation. Come here tonight. So I've chosen a title that is a bit maybe provocative. Cancer pain, is it a unique entity? And so we'll discuss this among some other things. But first, I think we should start by defining what is pain. And so the definition of pain, this is the official definition of the International Association for the Study of Pain, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. As you can see, I put the last sentence in red because many times patients will tell you, doctor, I feel this is burning, this is like someone's putting needles in my arm or in my leg. But we don't see anything. We just rely on the patient, what he or she is telling us, and the description is as if my bones are broken, etc. We must listen to our patients, and this is part of the official definition. Also, I would like to emphasize here that when we are going to talk about pain, there's a major difference between the experience of acute pain, which each one of us experiences on a daily basis, and the experience of chronic pain. And so I will not repeat every time acute pain or persistent pain or chronic pain, but just for you to know that the word pain or the experience itself could be different in many respects, including the origin, pathology, and of course the therapy. But again, when we ask ourselves what is pain, pain is the combination of perception. So our brain eventually tells us that something is wrong with this or other part of our body, but it's also a verbal expression. So if I sit in front of a patient, I know she or he is hurting because she or he is telling me, doctor, I'm hurting. And you have here, for examples, where we should ask whether or not it's pain. So here we have a picture of a young baby, and she cries. There could be multiple reasons for that. She might be missing her mother. She might be hungry. Okay, she might have some pain, but in her age, she cannot tell us I'm hurting. So I don't know if I can attribute this behavior to pain. And on the other side, you have a rat. This is a rat where some kind of pain, we try to create a pain model by injuring one of the paws. You can see that the right hind paw is being put in a bit of an awkward position. We assume that the rat is not very happy. And we assume that some feature of its behavior could indicate pain, but the rat cannot tell us I'm hurting. That's why we can call it hypersensitivity, we can call many things, but we are not allowed to call it pain. Pain is when the patient tells me, doctor, I'm hurting. And the evolution of pain, this picture appears in every talk on pain, in every textbook on pain. This is from the 17th century. Descartes is the one who created it. And this is the way he saw pain. So you have an injury somewhere in the periphery, and there is a cable going all the way to a bell in the brain. The bell rings, and then we know that we have pain. Truth is that he was not so wrong. I mean, this is exactly what's happening. It's just a little bit more sophisticated. So when you look at it now, we know that there is the sequence of events here. There's something happening in the periphery. There's injury. There are some tracts that go all the way to the spinal cord, and the spinal cord to the brain. And there are some systems going down for the brain again with some kind of a negative or positive feedback. And this is the system that enables us to feel pain and to respond to it. And if you want to see how it looks, this is a bit more sophisticated with some fancy names on where it starts and where it goes. But again, this is the same parameter. So it starts from the periphery, going all the way to the spinal cord here, and then going to the brain, to various centers that are involved with the pain perception. I think that we all, the pain clinician, thinks this is one of the most important things that happened to the field of pain. Actually, it happened, I think, in the field of humans' well-being. And this is the gate control theory of pain that has been created by Melzack here from McGill and Wall, and it has been presented in 1965. And their theory was that pain is not just one-on-one thing, that you have an injury, it goes through the cable and goes through the brain. There is some control on how many of the painful impulses we can feel in our brain. And there is some kind of a gate that could control it and allows more or less pain to be felt. So I put just a few mannequins to show you that the system is more complicated, and it could be much more complicated. But this, I think, a picture here tells you the whole story. So we have, on one hand, painful stimuli going through some kind of different types of nerve fibers. And we have also non-painful stimuli that go through other pain fibers. And actually, they compete somewhere in the spinal cord or in certain areas of the spinal cord on whether or not the gate will be open or closed. So these guys are the bad guys. They want the gate to be open. These guys are the good guys, and they want the gate to be closed. And there are many factors that determine whether the gate will be open or closed. Just to give you a hint that this is the reason why you have two patients with exactly the same pathology, the pain could be totally different because the gates are not at the same condition, at the same stage, at the same time. And here is a list of some of the things that can open or close the gate. So the gate will be more opened when, because of sensory factors like tissue damage or inactivity. We know that patients who are people that are idle could have more pain, not exercising. We know that there are multiple cognitive factors like focusing on the pain all the time, negative thoughts about the pain and its consequences. And there are the emotional factors, depression, anxiety, anger, helplessness. All of these have been shown to open the gate. On the other hand, the gate could be closed. And closing the gates could be done, again, by sensory factors like increased activity, doing sports, going to the gym, medications of course, and relaxation and meditation. All these have been shown to enable us to close the gate and theoretically feel less pain. The cognitive factors, outside interest, distraction, and the emotional factors are positive attitude and stress management. All of these have been shown to close the gate, and it's true to patients with non-cancer pain and patients with cancer pain. Now, just a bit of statistics so that we know what we're talking about, and the statistics are quite significant. So we know that at diagnosis, when there's a new diagnosis of cancer, around 50% of patients already have some pain. Sometimes pain is the initial factor that brings patients to begin with to the physician. During treatment, around 60% of patients report pain. In advanced stages, we're talking about 65% of the patients. In cancer survivors, those that have been cured, okay, and they do not have any active disease, still around 30% will have pain. And we know that in some cancers, pain could be in most patients. For example, cancers of the head and neck cancers, or 90% or even more of patients will report pain sometimes during the disease. And the estimates vary. I mean, if we look at the epidemics of pain, it's quite difficult to determine because it changes so much. It depends which center does it. It depends how you run, what kind of standardization you have. And we know that the pain conditions could be very heterogeneous, and the therapies are different from one patient, one center to another. So we are talking about estimation, but the percentage is really high. And the question is, and this is a question that I was asked in preparing for this talk, asked me, can you give us a hint, how do you, the pain clinician, understand cancer pain? So I gave it a thought, and I'll give you some thoughts about it. First, there is a simple way, the easy way, based on the pathophysiology. We know that there is what we call nociceptive pain, which is pain when a certain tissue is damaged. Okay, I have a pathology in the bone here. There is what we call a visceral pain that comes from our internal organs that could be affected by the cancer. There's a neuropathic pain, that is pain that follows some kind of a nerve injury or damage. And there is the non-physiological pain. Sometimes people call it psychogenic pain, which is not the right title. I put it here with question mark. We don't like to use it, but we know that it's impossible to have persistent chronic pain without having some psychological sequela to that, depression, anxiety, etc., etc. So these can contribute to the pain. And then we can base our understanding on the pathophysiology of pain. So first, pain that is caused by the cancer itself. We have an X-ray here of a patient with a metastatic disease to one of the bones in the leg, and clearly this lesion brings upon pain. So the cancer itself is the reason for the pain. We know that cancer treatment could be associated with pain. So many patients with cancer undergo surgery, and we know that they could have acute pain after surgery, and sometimes this acute pain could persist and even become chronic. And we know that many patients will receive radiotherapy as their therapy, and this again could be associated with the pain sequela, and chemotherapy that again could be associated with some chronic pain conditions once even months or even years after it had been finished. And another pathophysiology phenomenon is the patients that become debilitated. For example, the immune system doesn't work so well, and that could be then develop pains that relate to this. This is an example of a patient with cancer that developed, in this case, acute herpes zoster or shingles that could become chronic. Again, it's not the cancer itself, but it's a direct result of the disease. And there are many cancer patients that are allowed to have also pain that is not related to the cancer. So this is an example of an elderly gentleman who has what we call degenerative spine disease, which happens to each one of us when we are getting older. And so this patient might have cancer, but he also has low back pain and difficulties in walking just because of these profound changes in his spine. And if we look at the etiologies, the reasons to have cancer pain, this is roughly the statistics. So in 3/4 of the patients, the cancer itself is the reason for the pain. In 50% is a treatment. In 8%, it has nothing to do with cancer. There are other reasons that could bring the pain. And again, there's another simple way in trying to establish definition of what cancer pain is all about. And this is the simple pqrst rule with which we're trying to define, better define the pain that patients are having. So we know that there are some provocative tests or provocative movements that could increase the pain. We try to understand the quality of pain, because if the pain is burning, it might be from different source compared to the pain that is described as a pressure. There's a radiation of the pain. I have pain here, and it goes all the way down to the foot. It gives me some hints what the origin could be. Severity, of course, of the pain, of course, and the timing. Is it all the time? Is it only during the night? Is it only when I eat, etc.? And trying to understand cancer pain, we must know how to measure pain. So this is just a few of the scales that we're using here, and I'm not going into details on each one of them, but they're on a daily use in trying to define pain. The only problem is that many of them are having a limitation. So how can you measure pain in someone who has cancer with all the emotional, social sequela that accompanies this, with a simple scale of no pain to worst pain possible? Okay? Sometimes it will be 10 because the patient is depressed. Sometimes it will be 10 because the patient just received a very bad news about his or her disease. So these measures they're limited. They're good, but they're limited. They cannot give us the whole answer. And don't forget that the pain experience is much more complex. It's not just, doctor, I'm hurting in my foot, and it's 7 out of 10. The pain comes in a very a complicated context of pain, who the patient is, about attitude and beliefs, the psychological distress that accompanies the pain that accompanies the cancer disease. The illness behavior, we see it on a daily basis. Different patients behave differently when they're having pain due to cancer. And all this is in the social environment that is so different between one person to another, between one community and another, between different ethnicities, et cetera, et cetera. And so the pain experience is really complex. And many times we don't know the whole story. This is why it's so important to find out when we are trying to treat these patients. And the questions that I want to raise here, and I said that I am teasing you a little bit with some provocative question. If you read in the popular media or in the scientific literature, we always divide it to non-cancer pain and to cancer pain. And the question is whether or not it's justified. And I can tell you that there are some authorities that claim that it is not. And there are some reasons behind it. First, we know now that with the advance in medicine, there's a longevity of many people with cancer, and they can develop other pains. So cancer pain, patient with cancer pains that develop pain in the leg, would you call it a cancer pain or would you call it non-cancer pain? And it's a bit strange. And the same is true for people with non-cancer pain who suddenly or eventually might develop cancer. And the categories of cancer versus non-cancer pain are often not distinct categories. I'll give you one example, and I'll show you in the next slide. Patients who have what is called peripheral neuropathy, this is a disease of the small nerves in our limbs, mainly in the legs, that develop burning pain after chemotherapy. But the same type of pain exactly could exist also in the patients with diabetic mellitus who do not have cancer. So it's not distinct just for patients with cancer. And we know that the pain mechanisms, when we look at the pathophysiology of the anatomy of the pain, could be quite identical in cancer and non-cancer patients. And this is a few examples to tell you that these claims are based on something. So just two examples. One example is one patient with chronic pancreatitis. It is a chronic inflammation of the pancreas. Could be seen by patients who drink, by people who drink a lot of alcohol. And the pain of patients who unfortunately develop carcinoma, cancer of the pancreas. The pain many times is exactly the same. Severe pain here going to the back. And just from the pain description itself, it's not so clear whether or not we can differentiate. And I already mentioned to you the peripheral neuropathy, this very painful pain in the limbs that could come after chemotherapy or to come due to other diseases, like, for example, patients with diabetes. Sometimes it looks and feels just the same. And the last things that people claim is that, unfortunately, not always, and now we see it less, but still the approach to pain, mainly non-cancer pain, but sometimes even to cancer pain, is that we have to adopt the easy way, what we call the reductionist model, to treat chronic pain, which means there is a broken part, let's take care of that. And this is true for both cancer and non-cancer pains. And by doing so, we ignore the complexity of the pain experience, especially when it's chronic, regardless of the etiology. So people say, this is common for both. We should call it just chronic pain or persistent pain and not divide it between the cancer and non-cancer. It is not true, however, and I truly believe that cancer pain is a unique entity. And I think that one of the most important reasons is, and I'm very blunt here, for most people, when they hear the word cancer, they think about lethal disease. Even though the cure rate now is so much higher and the life expectancy is much longer, still, when you ask people what they think about cancer, they think about death to some extent. And this is true only for patients with cancer pain. We know that, and we know that, yes, there is increased mortality also among patients with non-cancer pain, but it's not the same here. And it's rare that diseases that are non-cancerous are associated with such a high rate of pain. So cancer is unique in this because, as I showed you before, most patients with cancer will develop pain sometimes in the disease. And it is unique, and I'll divide it to the patient and then to the clinician. So cancer pain is unique because in the patient, we know that in contrast to many other people with chronic pain, non-cancer pain, the origin could come from many origins. It could be inflammation, it could be visceral pain, I explained to you. It is less common in patients with non-cancer pain. And we know that what is unique in this particular group is the fear that pain indicates disease progression or recurrence. And patients who had cancer that have been cured, if they develop a new type of pain, they might think first about whether or not the disease is back. It doesn't happen often with non-cancer pain. Many times patients are afraid to report pain to the treating physician because they're afraid that if they see they have too much pain, they might even decide to stop therapy because it's too much for them. And many or some cancer patients do not believe that anything could be done. However, and this is one very important thing that I would like to emphasize, that one of the major differences is, and it would be a surprise for you, for us, the clinicians, treating cancer pain in general or efficiently treating cancer pain is easier compared to non-cancer pain, to chronic non-cancer pain. I know it sounds a bit strange, but this is the truth. Our success rate with cancer patients is higher. And cancer pain is unique also because of the providers. We know that in cancer patients, many times we think about palliation, whereas in non-cancer pain, it's restoration and improved function. There is a chance that the physician will be willing to provide more aggressive therapy because of the type of disease they're having, and less fear of side effects or even addiction because of the specific type of disease these patients are having. So they are different patients with cancer pain. And my last slide, I just want to emphasize that understanding cancer pain doesn't mean we accept it. And we are not there yet. As you have seen, the statistics are not good, and we must work harder in trying to alleviate pain in most patients. Thank you.
Thank you, Dr. Shear. So we have a better idea of what pain is now. But how can we have better models to study to try and help those patients with pain? And this is what our next speaker is a specialist at. Dr. Svetlana Komarova will be Thank you. So Dr. Svetlana Komarova, she completed her, as the name implies, she completed her undergraduate education in physics at Moscow State University in Russia. She obtained a doctorate in biophysics from the Institute of Theoretical and Experimental Biophysics, now I'm not sure I'm going to say this right, in Pushchino, in Russia. She completed then postdoctoral training at the NASA Ames Research Center, the University of Cincinnati, and the University of Western Ontario. So she's traveled a bit. Now she's a tenured associate professor at the Faculty of Dentistry at McGill University, and she's cross-appointed to the Departments of Anatomy and Cell Biology and Biomedical Engineering, and she's a staff scientist at the Shriners Hospital for Children in Canada. And she's going to talk to us about pain due to cancer metastasis to bone. Can we examine it in preclinical studies? Dr. Komarova.
Thank you for the introduction, and thank you for the invitation to talk. So I'll give a very different perspective because, like, as you heard from my background, I really don't work with patients, and I don't have any expertise in human pain other than my own. But I work with mice, and that's what I'm interested in. And I'm the bone specialist. I study bone physiology. So the pain thematics is actually new in my laboratory, and I only do it in collaborative studies. And this is why I want to put the acknowledgements for the people I collaborate with right on before the talk. So Darin Abdelaziz was a graduate student who did most of the studies I will show today. And Dr. Laura Stone is an actual pain specialist from McGill, who I collaborate with in the studies. So I'm interested in bone physiology and bone health. And cancer has very special relationship with skeleton. There is primary bone cancer, sarcomas, but they're not very common. However, bone is one of the most common sites of metastasis from many carcinomas or from hematological cancers. And in 70 to 90% of patients with metastatic breast cancer, for example, the bone metastasis will occur. And with this bone metastasis, there are side effects and complications, such as hypercalcemia, vertebral compressions, fractures, and pain. So our initial question was, okay, how does this happen? What happens in the bone? So this lesion, like you can see, this is the hard tissue, and this hard tissue is now gone. So what happened there? There are many steps that are involved in metastatic cascade, starting from the primary cancer and all the way through the blood vessels and finally to arrive into bone. And I only focus on the very last steps in the bone metastasis, when cancer cells are already arrived to the bone and how they're able to change the whole system to accommodate their life. So there is this concept of vicious cycle that cancer cells elicit in the bone. So normally our bones are not static. They maintain through the constant balance between cells that form bone, osteoblasts, and cells that resorb bone or remove bone, osteoclasts. So when cancer cells arrive, they produce all types of factors that affect bone tissues. And they stimulate osteoclast formation, both through production of this key cytokine that is master regulator of osteoclast, RANK ligand, and through some direct actions. And then osteoclasts produce all kinds of factors that were stored in the bone, the growth factors, that then stimulate more tumor formation. So this interaction, productive interaction with local bone cells is really important for tumor. And in our studies, we looked a lot into how this happens. So if you look on osteoclasts, so this is below is osteoclast membrane, and this is the signaling pathways, the normal ones, and we looked how tumor cells affect them, and we found all kinds of different pathways being activated and the new mediators that are being produced. Again, I will not go through the list. It's because I need to get to the pain part. So, and we identify one of the particular pathways, which was very interesting as a target for treatment, and that is an mTOR pathway. And what you're seeing here is our study demonstrating how cancer cells, which are here are 41, is the cancer cells, how they stimulate this pathway, mTOR pathway, in osteoclasts. So this is how cancer cells stimulate osteoclasts, which then will destroy bone. And it's a good target for treatment because there are medications that already exist that are used for different conditions that may be utilized here. So that was our interest, that it is a targetable, druggable target. So rapamycin is such a treatment that is used as immunosuppressant in transplant patients, for example. It's not quite immunosuppressant, it's immunomodulator. However, it's interesting because it also has antiproliferative activities. And it actually is used to treat some cancers. However, there is caution. But new treatments of the same family are now being explored. So we used this target when we developed our first mouse model on, to really directly see, can we inhibit osteolysis in these mice with the cancer metastasis to bone. And indeed, we have found that the lytic metastases are induced in incidence and that the survival is significantly improved. So with that model, I was asking this question. So, okay, we have the model which has cancer in the bone, and we study how treatments affect this model. However, we know that in spite of knowing that the cancer is painful, we never really try to assess pain. We only look at physiological targets. We look at tumor size, at destruction size, but we never consider pain as a practical outcome in these studies. However, if you look from the patient perspective, even if the drug is not perfect in changing the physiological outcomes, pain relief is still a very significant benefit. So we should have some sort of way to address it. So how can we do this? And this is where I started the collaboration with Laura Stone, and she taught me on how to do this in mouse studies. So, like we heard from the previous talk, in patients it's easy. You ask the question, they tell you. Does it hurt? How much does it hurt? Where does it hurt? When does it hurt? In animals, you cannot do that. They don't have verbal communications. Nevertheless, any of us who have pets had experience of knowing that your pet is in pain. So there are ways to see if the animal is in pain. So for example, here, you have these 4 animals. Can you tell me which ones are in pain? 1 and 3, right? So we have no doubts. There's this specific facial expressions, the squinted eyes, the ears are back. You can see that the posture overall is rigid. So there are nonverbal signs of pain. So what they are, and they're actually quite similar to nonverbal signs of pain that humans experience. So, for example, okay, if you're a doctor, the patients come to you and tells you that I'm in pain. But if you are a nurse and you walk down the ward, you may approach the person and thinking that this person is in pain because of nonverbal signs, right? So vocal complaints, nonverbal vocal complaints, signs, gasps, moans, or cries, and similar nonverbal complaints, vocal complaints occur in animals. Facial grimaces, like there is a relaxed face of the person who is not in pain, and there is a face of the person who is in pain. And similarly, there are facial expressions in ears, whiskers, and eyes of animals that we just have seen are very clear. Restlessness, like rocking, inability to keep still. Similar is observed in animals, restlessness or immobility, rubbing, and similarly licking or biting the affected area in animals. So there are ways to study, to observe pain in animals. Do we know if it's pain? Well, again, maybe not, or at least not exactly, because there are many components that will contribute to pain, including ill health, physical impairment, distress, anxiety. All these parts will also contribute to pain. And if we take an experimental cancer model, indeed, animals have cancer cells and they are unhealthy. If we study bone metastasis in particular, we place these cancer cells in the leg, so the physical impairment will be there for certain. And there is a distress. Mice and rats are nocturnal animals, and we study them during the daytime, and any handling is stressful. And I will not even go into anxiety, because that is above what I can talk about. So what can we do? We can try to address these problems in the way we design our experiment. For example, for ill health, we use slower cancer models, something where the cancer is not very aggressive, so we will not create the fast situation of ill health in an animal. And then we can see slow pain development, avoid severe damage and numbness that is common at the end stage. To minimize distress, we can adapt the animals to procedures. We can do it repeatedly before initiation of actual experiments, so the animal will be used to handling and used to undergoing these tests. And for physical impairment, I'll show you a little bit of data that allows us to somewhat separate. It's not perfect, but we can have some separation of actual physical impairment measures, which also relate to pain, and the measures that relate to more pain, much more than to physical impairment. So, in our study protocol, we have two groups right now. We have sham animals that have an operation but don't have any cancer, and we have cancer-bearing animals where there is an injection of cancer cells in the tibia of the mouse. So we use immunocompetent model. Although we cannot put human cells, it's a disadvantage that we cannot put human cells in this model. However, the advantage is that we can take into account any immune-related systems. And remember, because our target was mTOR and our drug of interest was rapamycin, which is immunosuppressant, we thought that it's really critical to have immunocompetent mouse, not to miss any immune-related effects. And also, these mice are easier to test because we need to test them repetitively. We use lower dose of cancer cells. We have 3 weeks of pre-testing. So for 3 weeks before actual start of experiments, animals are tested for baseline activities. And we have a large battery of behavioral tests which target different aspects of pain-associated behavior. So we pre-test for 3 weeks. Then we inject the cancer cells or control or not in sham group. And then we study these animals for 5 weeks after. So how do we study? First, we look into just development of the cancer. So do we really create a cancer model? Yes, we do. We can see that these animals which have cancer cells in them have overall general weight loss. It's a sign of cancer. And also on the X-ray, we can see development of macroscopic lesions. Not the tiny one, but really macroscopic lesions. And you can see that this lesion size, they're evident after 3 weeks after injection, and they're increasing with time. So now, the next step is to try to assess pain in these animals. And first thing we do is to study spontaneous pain measures. And to study those, we just place animals, so there is a mouse, you can see a mouse, in the glass box, plexiglass box, and we monitor its behavior. So pretty much we videotape it and then analyze the videotape. And what can we see? We can see how much they limp. We can see how much, we can actually see how much they travel, like the whole distance they walked around, and how much they guard. So guarding is actually taking off the leg that is being injected and not exposing it to walking, to prevent it, to protect it. In this set of assays, more pain will result in more limping, more guarding, and less walking, but more physical impairment also will result in more limping, more guarding, and less walking. So this test assesses both, the combination of physical impairment and pain. So, and here you can see that bone metastasis leads to changes in limb use and in guarding. So with time, and again, look at the time course. This is 3 weeks after the injections. This is the same time when we see macroscopic lesions. The animals start to limp more and more. And the guarding is also increased at that time, and then it decreases later on. And the way we interpret it is that there is physical impairment in limping and in inability to guard later on. However, this initial increase in guarding is likely due to pain. So first, the pain results in more guarding, and later on, when the physical impairment is too much, they cannot guard anymore. They just cannot maybe, lift the limb. So in the next set of pain tests, we look for the measures of evoked pain. So in this set of assays, we expose the animal to something that is potentially painful. But at the levels where we start at the levels where it's not. And we look at what point the animal reaches the sensation of pain. So for example, when we study mechanical sensitivity, we have this battery of von Frey elements, very, very thin elements of different thickness. And what we do is touch the animal's paw with different elements, and we look at what size the animals start to withdraw. So initially it's not painful, it's just, like very, very mild touch. But at certain thickness, the animal will withdraw the paw. And the lower the thickness, the more sensitive the animal is to the mechanical stimulation. Similarly with heat, we apply the heat source and we measure how many seconds it takes for the animal to withdraw the paw. And for cold sensitivity, we apply the drop of acetone, and we again measure the time the animal engaged in. It will bring the sensation of cold, and we measure the time the animal is engaged in licking and biting the area. So, and the longer they do it, the more sensitive they are to cold stimulus. So, and in these measures, if there is more pain, they will withdraw faster or react longer to cold. But if there is more physical impairment, they will be more slow to withdraw, and they will, the reaction to cold will be shorter. So here, we are more confident that whatever we are measuring is related to pain rather than physical impairment. So, and here again, we can see that bone metastasis leads to hypersensitivity. And in this graph, this is hypersensitivity to heat. So this is the latency of withdrawal. So what is the threshold for withdrawal? You can see that at baseline, the animals have the same thresholds, which remains the same for 2 weeks after injection. However, at the same time, when we see macroscopic lesions, we see osteolysis, which is quite massive, the sensitivity in cancer-bearing animals is increasing. So they become hypersensitive to heat. And the same or similar behavior we observe when we test for mechanical and cold sensitivity. So in any of the tests we use, the cancer-bearing animals exhibit the behavior consistent with more pain. So now back to mTOR. The very interesting fact about this pathway, the mTOR pathway, that it's universally important because mTOR controls protein translation, which in turn controls cellular proliferation and energy metabolism. So we have demonstrated that it inhibits osteolysis. However, in addition to that, it has been shown to have beneficial effects on cancer itself. So if you inhibit mTOR, you inhibit proliferation of cancer cells. And also in the models of neuropathic pain, it has been shown to be beneficial and act as an analgesic. So Now we use the same animal model as I showed you before, and in addition to the two groups, the sham and cancer-bearing, we introduce two groups which have treatments. And there are two types of treatment. One is rapamycin that targets mTOR, the one that I told you before, and another is pamidronate that directly targets osteoclasts. And the osteoclasts, we use this treatment as a control in a way, because remember how every time we look at pain, it appears when we have massive osteolysis. And osteolysis is an action of osteoclasts. So osteoclasts are the cells that resorb bone. So we were thinking that if we prevent bone resorption, maybe we will help with pain as well. So what we found was, indeed, both drugs, both rapamycin and pamidronate, delayed the development of cancer-induced bone loss, guarding, and hypersensitivity to heat and cold. And here I just show you two graphs, guarding and cold sensitivity. And for both, you can see that, so this is now difference from baseline on the guarding. This is the control group that doesn't have cancer cells, that don't have any guarding. This is the cancer group, which has quite, a bit of time spent guarding the limb. And those are two groups treated with either rapamycin or pamidronate. Although they still guard, it's not a complete reversal. They guard significantly less than animals who don't receive any treatment. And the similar effect is for cold sensitivity. Again, both drugs, they didn't reach the levels of the control animals, but they're significantly better than cancer-bearing animals, which are not treated. In addition, we have found that rapamycin specifically, only rapamycin but not pamidronate, also delayed the development of cancer-induced mechanical hypersensitivity. So here you have mechanical effects, sensitivity to mechanical stimulus, and again, so the pain difference goes like the other way compared to the previous. So the control is in white, so they're not very sensitive. The cancer group is much more sensitive than control group to mechanical stimulus. And you can see that while pamidronate in green behaves similar to cancer group, to untreated group, the rapamycin treated group is similar to control. Importantly, in these studies, we could not block any cancer development. We could only delay the effects on both osteolysis and pain. And even in the end of the study, well, by the end of the study, neither rapamycin nor pamidronate could prevent osteolysis or pain. So both the effects were temporary. And this is very interesting because pamidronates, at least to me, this is not pain, this is bone physiology. Pamidronate or other bisphosphonates are known to be extremely effective in blocking osteoclasts. And yet what I'm showing you is that in the contralateral tibia, pamidronate perfectly preserves bone volume, but it is unable to do this in the cancer-bearing limb. So it's not able to act as an inhibitor of osteoclasts in the presence of cancer cells. So in other words, there's still lots of things we can do. So in conclusion, what I have shown you that breast cancer bone metastasis in mice is associated with measurable pain. And being measurable is really important for preclinical development of drugs that can target it, because if we can measure outcome, we can measure that it's reduced. So studying different interventions in pain control would bring different drugs to the target, which may or may not be beneficial, like extremely beneficial to the primary outcomes, like physiological outcomes, like cancer, tumor size or osteolysis, but still will be beneficial for patients. So targeting mTOR reduced osteoclast activation and limited neuronal sensitization and hypersensitivity to mechanical and thermal stimuli. And it's a very promising drug for pain relief, at least based on our study. Osteolysis, just destruction of the bone, appears to directly contribute to pain, and osteoclast targeting therapies provide quite significant but not complete pain relief. And bone loss in cancer-bearing site was not prevented by rapamycin or pamidronate. So that's it.
So thank you, Svetlana. Our third speaker tonight is also a clinician, I think so. Dr. Manuel Borod. He's the director of the Division of Supportive and Palliative Care at McGill University Health Center. He's practiced medicine for 20 years prior to embarking on a career in palliative medicine. He developed the home care program at Mount Sinai Hospital prior to coming to the MUHC on a full-time basis. He served as clinical director of palliative care from 2003 to 2009, and since then, he's been the division director. He's been very active in improving and developing outpatient services, which include a palliative daycare hospital, a cancer rehabilitation program, and a multidisciplinary cancer pain program. He has long been a dedicated teacher and mentor to medical students, residents, and colleagues. Dr. Borod has also given many presentations at local, national, and international conferences on a number of subjects, including cancer pain, ethics, palliative sedation, and euthanasia, and the role of humor in palliative care. Tonight, he's going to talk to us about a unique approach to cancer pain management. Thank you for being with us.
Well, thank you for having me, and thank you all for coming. It's so nice to see so many people interested in this subject. Some of this information at first will be, you have heard some from Dr. Shear, but now we'll reinforce this information. And I think what's sometimes striking is how much pain people have during the whole trajectory of their illness, not only at the time of diagnosis, when about half the patients have pain, but throughout the course, certainly in more advanced stages, the pain is more prevalent. But even amongst cancer survivors, for a number of reasons, there is significant pain as well. And what happens is, as we all know, that this is very relevant. When a patient has a big tumor that's causing a lot of local invasion and pain, there's going to be a number of consequences. One will be that there's numerous physical symptoms, but it's also going to have a significant emotional impact on patients. It's going to have an impact on the relationship that patients have with family members. I had a father recently with 2 young children who was unable to get on the floor and play with his kids until his pain was better controlled. It has financial repercussions because patients are no longer able to work and provide for their families. And of course, pain can have an impact on survival. In fact, if we look at a couple of studies that were done, you can see here that patients who had an implantable drug delivery system lived longer than patients who had conventional medical treatment. And you see also that patients with pain survive less long for patients with metastatic prostate cancer. Some of these differences, if they were applied to clinical trials and chemotherapy, would be considered very significant and would lead the road or lead the way to many more trials. When we look at at trying to classify cancer pain, clearly there are times when a patient has a high disease burden and the pain itself is directly causing pressure on adjacent structures, on nerves, on different organs, and it's clear what might be causing the pain. In other cases, patients have surgery. Clearly, we all know that surgery may cause pain, but subsequent to the surgery, there might be continuing pain syndromes as a result of damage that occurred during surgery. Chemotherapy can cause very significant pain issues as a result of some of the agents being used. And sometimes when patients are receiving radiation, as a result of the radiation itself, patients will continue to have pain. As mentioned a little earlier, there's pain related to debility. There's pain related for different immunosuppressive therapies. And of course, having cancer doesn't mean that you can't have non-malignant causes of pain. And in fact, often patients who have cancer may be less mobile and more at risk for some of the other pain syndromes. This you just saw a few minutes ago, but basically, again, it still strikes me that so many patients have pain as a result of cancer treatment, and often this is neglected. And certainly, we are seeing many patients with cancer who are having pain, and we'll sort of show you a little in a few minutes how we deal with those patients. Another way of classifying pain is to look at whether a pain is what we call nociceptive, and those pains can be classified either as somatic pain. So typically, if you have a fracture, that would be a somatic pain. We know exactly where it's coming from and what causes it. You could have a visceral pain. That's a pain coming from an organ. And in some cases, patients who have angina, for instance, would be a non-cancer visceral pain. Patients with a gallbladder attack, those are patients with non-cancer visceral pain. And finally, we have neuropathic pain, which is anybody who's had sciatica, if they've had a nerve root inflammation in the neck and you have burning pain in your arms, that would be typical of a neuropathic pain. Now, I have to say, I heard earlier that it might be easier to determine pain in humans, but when patients often have neuropathic pain, they can't really describe the pain very well, and sometimes that is one of the characteristics of neuropathic pain, when patients find it a little difficult to be able to point to exactly where the pain is. And finally, we talk about total pain. And I think for us in particular in palliative care, total pain is a description that Twin Cross described many, many years ago. And it really talks about the interaction between the physical, the psychological, social, and spiritual. And as Dr. Shear mentioned a little earlier about the gate theory, he did mention the fact that perhaps there are emotional factors that could open or close the gate. And what we see in patients who are undergoing pain, the whole social structure of going for cancer treatment, the frustration sometimes in having a diagnosis, the inability to contact your care provider, the difficulties getting certain medications insured, all of these impact you on a social, on a spiritual, and in psychological ways, and these contribute in a very real way to the way patients experience pain. And whenever we bring that up with patients in terms of how they're managing their pain and how they're dealing with it, we are not in any way trying to infer that the pain is in their heads, but rather these emotional factors have a very profound impact on patients' pain. We know that pain can be acute or chronic, and again, the acute pain can be treatment-related or it could be related to some complications around treatment. Breakthrough pain would be when a patient has pain that is controlled, but at certain times of the day, the pain breaks through, it gets worse, and we have to adjust the pain medication. And of course, chronic pain could be disease-related, but it also could be treatment-related. For example, either chemotherapy, or patients could be on steroids, which causes osteoporosis, which could lead to fractures, and it could be non-cancer related. We also can classify cancer pain by severity. This study was done a number of years ago, but basically at that time, 40% of patients reported pain. But of those patients, 2/3 of them described their pain as the worst pain possible. Whenever I talk about cancer pain to students, I bring up the question of assessing pain. And the reason I do that is because it sort of seems clear that if a patient has cancer and has pain, they have cancer-related pain. But the same patient may have had cancer yesterday and didn't have pain, and today they have pain. And so we have to really get to the root of what's causing the pain. Is it persistent? Is it, as I mentioned, breakthrough that's transient? Do a psychosocial assessment, a physical exam, and look at some of the imaging that needs to be done. And every time a new pain is reported, we really have to investigate it. And it could be either a change in the underlying process, or it could be related to other factors. A typical example would be treating a patient with pain who may have bone-related pain, as an example, and is in the hospital, and would get a call from the nurse that the patient is in a lot of pain. Should they increase the pain medication? Of course, you know, the natural answer might be yes, but perhaps you might ask, well, what's causing the pain now? And in fact, it's not the same pain, it's abdominal cramps, and the cramps might be related to constipation, and rather than increasing the pain medication, perhaps we should be targeting what is actually causing the pain. This is an ongoing problem within hospitals with teaching to make sure that we assess the patients properly and investigate them when necessary. Now, what are the principles of actually managing patients' pain? The World Health Organization published years ago what was called the pain ladder. And it would start by basically prescribing medications such as Tylenol or ibuprofen for patients with pain, and at least start with something. And if that's not working, maybe to go to a medication that might be a little bit stronger, and some of them might be tramadol or codeine. And then finally to bring in our heavy artillery such as oxycodone, morphine, methadone, and fentanyl. Although I think with time it's been proven that really because the side effect profiles are actually better and the effectiveness is better as well, that we really skip step number 2. And if a patient's in pain and not responding to Tylenol or ibuprofen or naproxen, for example, that we would go ahead to give oxycodone, fentanyl, or one of the other opioids. Now, this sometimes scares people because more and more we hear about opioid abuse. Right now, it's a fentanyl scare that we hear about. And we read about it in the newspaper every day. A few years ago, I was in Florida, and there was an article there about oxycodone. So whatever the opioid is, whether it's oxycodone, fentanyl, hydromorphone, there's going to be potential for abuse. We don't actually see that, or we see it very, very infrequently with patients who are suffering from cancer-related pain. And we often have to reassure patients that it's okay to take pain medications if you're in pain, because they could be quite effective, and being in pain could really be detrimental to many of the treatments that you might want to be receiving. Now, I'm always amazed in our cancer pain clinic how we are able to manage patients on a relatively low dose of narcotics, or opioids as we like to call them. And when students rotate through our pain clinic, I'd like to highlight just a few things. And that is, if a patient's pain is difficult to control, there's usually a reason for it. And if we're going, for instance, giving a patient 30 milligrams of morphine a day, and then we give them 60 milligrams a day, and then we give them 120 milligrams a day, maybe somewhere along the line we should try to think of, well, why isn't this working? Why do we just keep increasing the opioids? Now, some patients become tolerant very rapidly, and their disease is progressing, and they may need more medication. Some patients may have had a history of alcohol or drug abuse, which may impact their use of pain medications, but we don't see it that often, but it can occur. Some patients were not targeting the right factor. They're in a lot of emotional distress, they're expressing pain, and sometimes the disease burden doesn't really match with the degree of pain they're having. And I'll always remember one patient in particular when I just couldn't understand exactly why he was in so much pain, and he was about 50 years old, and I asked him, how he was managing with his disease and how it was impacting him, and he just started to cry, and it was like bursting an abscess because it enabled him to express all the fears he had about his disease, about disease progression, and possibly dying. Incidental breakthrough pain, which is really probably one of the things that leads to the most unnecessary escalation in opioids, would be when patients have a pain that gets much worse when they do something. So if you have a fracture, for instance, in your arm, and you're going to brush your teeth, I can guarantee you that it's going to hurt. And rather than increasing the opioids all the time, because every day they're going to take 3 or 4 breakthroughs, and if we calculate that and we increase their opioids, eventually they'll be on an extremely high dose, rather than understanding that perhaps we need to keep the dose the same and pre-medicate them prior to some of the activities that are causing them pain. For instance, a patient who is rehabilitating after surgery might have pain with rehab, and we would want to pre-medicate them. For many different reasons, patients become delirious during a course of their trajectory of the illness. It might be because of reversible conditions such as infection, electrolyte imbalances, or it could be as a result of disease progression. But when patients are confused, it becomes more difficult to be able to understand and manage their pain as well. And finally, for patients with neuropathic pain, that nerve-related pain is often difficult to control. Some patients can be controlled really easily with a really low dose of an opioid, and other patients, if you, as I mentioned, keep increasing the dose and it's not working, maybe it's time to look for something else. So, what did we decide to do at the MUHC? As Dr. Shear mentioned, Dr. Melzack was one of the originators of the gate control theory. So McGill has a tremendous history in pain control. Balfour Mount created palliative care. So here we have 2 individuals who are world-renowned, and they're both in the same institution. So we decided a number of years ago, Dr. Shear and myself, so it's nice to see Dr. Shear here because, in fact, we worked together on this, to create a cancer pain program. And one of the reasons for that was that patients were being referred to the chronic pain clinic with advanced cancer, and they were not equipped to deal with those patients. And often the wait time for patients with chronic pain would be quite long. And on the other hand, physicians and clinicians didn't want to refer patients to the palliative care day hospital because the term palliative care scares people. And even though the patient may have been cured of their cancer, they didn't want to be coming to a cancer pain program or to the palliative care clinic when they had recovered from cancer. So we created together this program 5 years ago as an alliance between our supportive care program at the MUHC and the Allen Edwards Pain Management Unit. And we were fortunate to be supported in this by the Louise and Allen Edwards Pain Foundation. And what are our objectives? One is to provide excellent clinical care. We assess the patients, and we have an interdisciplinary team that includes a palliative care physician, an anesthesiologist, radiation oncologist, interventional radiologist, and most importantly, a nurse. And so we provide the patients a safety net. So when they're in pain, not only can we have a number of people assess the patients concurrently, but we also have a mechanism for them to get in touch with somebody if what we've done for them isn't working. We want to train individuals in medical school, in nursing, residents, our palliative care fellows and chronic pain fellows. And we want to do research. We want to know what the outcome is of an interdisciplinary approach. We're looking into studying regarding methadone, cannabinoids, and interventional approaches. We run this clinic 3.5 days a week, and we have some availability at other times. We do cover for patients in our palliative care clinic. Some days we have the radiation oncologist. If we screen the patient or triage the patient, we'll try to have them come. If we feel they have bony metastases, that we'll have them come when the radiation oncologist is there. And at other days, we have the interventional radiologist there as well. And as you can see, over the past 5 years, we've treated over 1,000 new patients through our clinic. We also work closely with the psychosocial oncology because, as mentioned, there's a tremendous impact of some of the fears and anxiety around cancer. And we also work with allied health by having physiotherapy and occupational therapy help us manage the pain patients as well. And what we can see is that patients have done well. Having even a 1-point improvement in pain is considered statistically significant. We've had better than that, but not only does the patient's pain improve, but all the issues around their quality of life improve as well. Fatigue, nausea, depression, anxiety, drowsiness, well-being, and shortness of breath. The only thing that doesn't improve is appetite, and probably that's more related with time, that the disease itself is progressing and patients might be deteriorating for other reasons. So in fact, the pain itself is improved, as are many of the other symptoms. And very often we do that without really escalating the opioids in a significant fashion. We combine various medications, but we also have about almost 30% of patients that receive an interventional approach. So if we're managing a patient with neuropathic pain and their opioid use is going up, we look for other options. Will they benefit from a nerve block, from a celiac block? Will they benefit from radiotherapy or psychosocial intervention if it's really total pain that's contributing? So some of the procedures might include, for instance, injecting cement into a patient's vertebrae, targeting various nerve centers for treating pain related, for example, to pancreatic cancer. And we have time, and with the addition of the radiation, with the interventional radiologist, it's expanded our ability to have resources available in terms of operating time, X-ray machinery, et cetera. So when we look at that ladder, in fact, we're changing the paradigm, because although the third step in the ladder ended with opioids, in fact, we want to add a fourth step, and that would be interventional pain procedures. And what we look at is that, in fact, another way to look at it is to put a handrail beside the ladder, because some of these interventions can take place at any time during the course of the patient's illness. So really, it could be a last resort in some cases, but I think what we look at very frequently is, before we start escalating opioids, can we provide an intervention that would diminish the need for long-term reliance on pain medications, which could increase constipation, as an example, and are there things like that we can avoid? We're looking into cannabis in our clinic. Everyone asks about cannabis all the time, so don't anyone ask about cannabis, but maybe after we study it a little bit, we'll have some answers. Right now, it's very difficult to get cannabis. We want to make it simpler for patients, but there's many regulations around it, which we're trying to understand how we could best meet the needs of our patients. Finally, I showed this before, but I didn't mention anything about our Cancer Pain Fellowship. We have the only cancer pain fellowship in the world where we actually invite physicians who have completed their studies to spend a year studying cancer pain, working in our clinic, working with oncology, with radiation oncology, with interventional radiology, with palliative care and anesthesiology to get a thorough understanding of cancer pain. Dr. Uri Hartberg finished his fellowship. There he is with his family. He was in Montreal for a year from the Iqlov Hospital in Israel, and he just returned after completing his year at the end of June. Dr. Perez is currently the director of the program. He splits his time between the Alan Edwards and our cancer pain program. I have to say he came back from Sloan Kettering a couple of weeks ago, where he was attending an interventional conference, and he couldn't contain his excitement because during the course of the presentation on interventional pain, they in fact used our model of the McGill University Health Center Cancer Pain Clinic to highlight the benefits of an interdisciplinary approach. And in 2015, we received the Prix de Cancérologie from the Direction de Cancer, from the Quebec Cancer Governmental Cancer Agency for our cancer pain clinic. We have many people to thank for the work that we do, and unfortunately, the government doesn't pay for all of the resources that we use, but we have foundations that do support us and for which we're appreciative, and we also appreciate the input from the other departments within the hospital, especially nursing. Thank you.
Thank you. You know what? Put some lights back on. Lights? Okay, so I'm sure you probably have lots of questions. If you want to write them down on your cue cards, we'll have some students pick up the cue cards and bring them down. And while this is happening, I want to tell you about something pretty special that's going to be happening, a special event that is going to be happening on Tuesday, February 27th. You should be receiving an email sometime shortly indicating exactly what it is. We have a special speaker coming into Montreal, somebody who's of an international stature on lung cancer and has changed a number of policies regarding how this is treated, who is paying for it, who's responsible for it. The tobacco industry is somewhat related to all of this problem. And basically, this is going to be happening at 4:30 in the afternoon that day. And the email and brochure that we'll be sending along with it should indicate exactly when, where, how to register and attend this event. If the speakers could come to the front table, please. So we'll start immediately. Dr. Barad, the first question is for you. Can pain go away by itself without an intervention? For example, via the body eventually ignores it, gets used to it.
I don't know if the body would get used to it. I think pain does go away for many different reasons, and certainly without interventions. Pain can go away because of treatments, whether it's chemotherapy, radiation therapy, and sometimes with time, although I would say for the most part we're following patients who are receiving concurrent treatment, and that would likely be the reason that patients improve, because they're targeting some of the other, the size of the tumor. Sometimes steroids, for instance, we can give a patient steroids, the inflammation goes down, we wean them off the steroids and the pain is gone.
How does one get into your cancer pain program?
Well, you need a referral. So if you would see your oncologist or radiation oncologist, because you do need a cancer diagnosis, and they would refer you to the clinic. Hopefully they'll have started something first and done some investigations before they come. That would be the preferable route.
I'm sure you've had these questions many times. Do you accept patients from other hospitals?
We do, but again, the patient should be referred. Usually at another hospital, the patient's being followed by a pain specialist, and in that particular case, we would probably want to speak to the referring physician and see if it's specific for an intervention. For instance, if a patient's at St. Mary's, they may not have an interventional pain specialist, so we would want to make sure that the patient's seen on a day when when it wouldn't be me, for instance, seeing the patient when there's already a palliative care physician seeing the patient at the other hospital. But we do see patients not only from other hospitals within the McGill network, but I've received calls from clinicians on the South Shore who have had very difficult pain management issues, and we will see those patients as well.
Okay. We can't avoid it. Where and how to get cannabis for neuropathic pain? And then why not talk about marijuana?
So where to cannabis? Come to my home later on. I'll give you. So right now in Quebec, medical cannabis is legal. The only constraint is that the patient and the prescribing physician should become part of what is called the cannabis registry, which means that every patient that receives a medical cannabis officially is part of a registry that follows the patient up for at least 2 or 3 years. And and every physician in Quebec is allowed to prescribe the cannabis as long as she or he joins this registry. You don't have to go to the street and buy it, even though it's a possibility. You can do it through your physician, and the physician doesn't have to refer the patient to a specialist to do it. Every physician, every general practitioner in Quebec has the right to do it as long as they are part of this registry.
I'm the one who asked this question. I went to a conference about 3 weeks ago at the Kitsun, and they were talking about cannabis, and they were talking about the kind of cannabis that doesn't have the THC because it can have a psychological impact, but the one that has the CBD.
So,
can you repeat the question?
Yes, the question is what the cannabis is not. It's not one product, and so there are certain products that contain more of one ingredient and contain less than the other ingredient. There are two, even though there are hundreds of ingredients in the fresh or in the dry leaves of cannabis. The two major ones are CBD, which is less sulfuric and has some analgesic properties, and the THC, which is the guys that gives euphoria. This is why people use it for recreational purposes. And we do know now that there are commercial products that contain various percentage of the two. So there are products that contain almost exclusively CBD and almost no THC, and the opposite is true. There are those products that contain a lot of THC and only minimal amount of CBD. And the decision what product should be given to a specific patient or specific condition depends on many factors that I'm not going into details here. But yes, your physician could ask, or the patient might ask the physician to recommend that she or he will receive mainly CBD in the product and not THC. Yes, well, here we are going, we don't know about it much because it's only we are seeing now only the first steps. There are not good enough studies on that. We don't have a clue, for example, what kind of pain condition will respond better to a specific type of cannabis. okay, of the various products on the market. Many times physicians are ignorant because they do not have any education on that, because there are not good studies that could educate physicians on what they do. So these first steps, you act by being careful, try to learn from others, use a bit of experience, and hope for the best. But it's true that if we used the use of cannabis today is many times experimental because we don't have enough good evidence to show that this drug is better compared to some others. Now, we do know that sometimes it's a miracle drug, and in other patients it doesn't do anything, like many other medications. So I want to reassure you, cannabis could be really good for some patients. I will not recommend calling it a miracle drug. It's not that cannabis solves all problems. It has a lot of other benefits in cancer patients, not just the pain. Increases the appetite, it decreases anxiety, it promotes sleep. So it's a very good medication, and it could help a lot of cancer patients. But again, it does not, there is no guarantees it will help all patients with all kinds of cancers in all stages of the disease.
But can it be found? Like, does it have a name, the one with more CBD than THC?
You should go to the internet and find out the manufacturers. It's not a secret. And there they will give, so consult with your physician.
I could just add, because that's a subject that many people ask, as Dr. Shear mentions, there's very little data on cannabis use for pain. In fact, what has been shown is it may be as effective as Tylenol. So it's certainly, I would doubt if it would be as effective as some of the other medications we use. And you mentioned neuropathic pain. There are really no studies that show it's effective for neuropathic pain. It does sometimes make people feel better, which is fine. It may help nausea, but again, there's not much data to show that it's better than other medications. It may help anxiety, but it also has side effects, because the patients we see are very fragile, and just adding another psychoactive drug isn't necessarily in their best interest. And patients are coming now because they think cannabis will cure their cancer, and again, there's no evidence for that. So we've opened the door, there's a lot of excitement about it, but the evidence isn't there, and I think we are trying to practice evidence-based medicine.
Can pain be treated by hypnotism?
I'll defer to Dr. Shear because, again, I haven't seen that used for cancer-related pain. It may be more of an issue for chronic pain than for cancer-related pain.
So again, in our clinic, sometimes we use hypnosis by our psychologists to treat chronic non-cancer pain. There are no good enough data in the literature to indicate whether or not it has a long-term effect. I can assure you that short-term effects, for an hour a day, we are seeing sometimes a very nice effect, but to recommend it for all patients, for all conditions, it's quite difficult. And we have no proof. So the answer is yes, it might have a potential. We don't have enough data. Just a comment on pain in general. We are quite not there now with knowing what to do with this. Really, I'm quite ashamed to say that. And so for so many things that you ask, the answer is going to be from the panel here. We still don't know. So it's...
Okay, let's test it again. Can humor increase the thresholds for pain tolerance in cancer patients?
I think, as Dr. Shear had pointed out in one of his slides, distraction can reduce pain, and I think humor is a form of distraction. I do have a slide in one of my presentations which shows a woman at her husband's coffin, and they said that he was feeling ill, and they called a comedian, and sometimes laughter isn't the best medicine.
Here's a very interesting question. Pain leads to worse outcome. Why? Because pain means the disease is more advanced, or because the patient gives up due to discomfort?
again, I guess I'll answer that question because it sort of leads to bad outcomes, and I see many of them. I think there's the combination of factors. Being unable to control the patient's pain is indicating that the disease itself is progressing. Either that or it's in a location that we can't target. It decreases mobility for patients, which itself is a risk for various factors. It increases the need for pain medication, which may lead to other complications. And in the very few patients that we actually really cannot control the pain, we will have to escalate their pain medications, and patients become more drowsy. There's risks of aspiration. And so there are many different factors for a patient with unrelenting pain to have a poor outcome.
Just one comment on pain and increased mortality. There have been not many, but there have been few studies showing that in some chronic non-cancer pain diseases, the chances to develop cancer are higher. And so there is some association between uncontrolled chronic non-cancer pain and the chances to develop cancer. But again, there have been only few studies that hinted that this could be true.
Can I ask a question to my colleague to the left?
Sure.
Okay. I was just wondering, your primary interest is bone metastases. Has there been any idea to look at the effect of radiation? Can you target mice and treat pain with radiation? Because that's probably one of the primary uses of radiotherapy is for palliative, is for pain control, for metastatic bone disease.
It's a very interesting question, and we actually had not only radiation, but the idea to have in mice the treatment that mimics what humans experience more closely, both with chemotherapy and with radiation. Radiation particularly is difficult technologically because we have to deliver it somehow to the mouse.
Right.
But it is a very, very good question.
Okay, there's a few questions on this topic. Why do we not see as much narcotic abuse in cancer patients as we see in non-cancer pain patients?
You know, for one thing, patients who have cancer and have pain do not get high when they take pain medication. And when their pain is reduced for whatever factor, whether it's chemotherapy or radiation, it's easy to reduce the pain medication and take them off it. There's no secondary gain. The psychological factors are different. It's almost unheard of that we see patients who become addicted, patients who don't have a previous history of drug abuse or addiction that become addicted to pain medication when taking opioids. And it's one of the first questions I usually have to address in trying to convince a patient that they shouldn't be afraid to take the opioids. Opioids are their friend. It's there to help them for their pain. They'll get better outcomes. They'll be able to continue their treatments. They'll be able to go for their chemotherapy. All of these things are in their best interest. And so being a hero, waiting for the pain to escalate to a degree that they need more rather than less opioid is a situation that we deal with far too frequently.
Someone was questioning about the cement injections. How do they affect the bones? And what are the benefits?
So this is a technique where if the bone is affected by metastases, a technique that strengthens the bone. So if there is a hole in the vertebra, for example, the cement that is injected inside could make the vertebra stronger and prevent further collapse of the vertebra. So it's a simple mechanical therapy in trying to stabilize, in this particular case, the spinal column.
Okay. Are there any attempts to understand pain from the point of view of patients and see how patients would be supported in some ways or strategies that might help them to cope and live with pain? So, you're looking at evidence-based? Are you questioning patients? Are you asking them to evaluate you are with some of your
We're always
tests.
evaluating pain and outcomes, and I think we're always looking for the role of the psychological impact, referring them when necessary. And I think probably an aspect of our pain program which is under-recognized is the role of the nurse within the cancer pain program to help the patient navigate through all of the distressing symptoms that they have. So I think we measure their anxiety, we measure their depression, we measure their pain, and we see them all coming down with good pain management.
Actually, I have a question. Sorry, I asked that question, and I was working in the chronic pain for the last 5 years, and as we know, it's widely like an attempt to understand how chronic pain or pain work like in experimental medicine. However, like there is many side effects of medications and all this thing, and chronic pain is lasting for a long time. So how we can understand pain from the point of patients that let them live with this pain? There is any system, supportive system to let patients live with it, like social support system maybe could have like, or some belief systems like religion and these things. My studies has shown like huge findings that could like work in any nations.
So I guess, and you're perhaps you're talking more about chronic pain that you've worked with. Certainly, in cancer-related pain, patients who are continuously in pain will have the support of, social workers, psychologists, spiritual care. We're a multidisciplinary team, and so if you can identify the source of the patient's suffering, we would try to target it. And I think in chronic pain, you also have psychologists, and I think it's certainly an issue. In terms of studying it, well, I guess there's only so many studies and so much money we have. So anyone who's interested in coming up with a study to look at that, by all means, if you can find the funding, go right ahead.
It has been shown beyond doubt that the treatment of chronic pain, and regardless now if it's cancer or non-cancer, in a multidisciplinary setting where we have social workers, psychologists, nurses, physiotherapists, etc., physicians, nurses, could yield better results. And there have been multiple studies showing it during the last 20 years. The only problem is the governments do not believe in that, and they are closing multidisciplinary clinics. And both our clinics, the Cancer Pain Clinic and our clinic, the Allen Edwards Clinic, will not exist without some private funding. So here, I'm saying without a shame that governments do not support enough. I'll give you another example. In the US, in the last 20 years, there have been, I think, 220 multidisciplinary universities, pain centers, and now the number is less than 70 because they also, the government believes in supporting some other missions. And so just for you to know that pain is not always on the highest priorities of governments.
One last question. Acupuncture to relieve pain, does it work?
So personally, I'm a true believer in what is called complementary alternative medicine, where every field of this huge field, when you try and see scientific evidence, the bottom line is not scientific evidence. So no scientific evidence. I think that the only field or the only arm of this that has been shown to be beneficial, again, in chronic non-cancer pain is acupuncture. I am not familiar with acupuncture in cancer pain. So I don't know if, Mani, do you know anything about it?
I would like to thank our three speakers of tonight. To follow up on what Dr. Shear has just mentioned relative to government funding, Those of you that were here at the first forum, if you remember, I was asking you to write, phone, interject, stop your MP and try to make them understand that they need to come up with funding. We are going to put on our website a link to a government survey. They're preparing the budget now. They want to know what you would like to fund. And we would really appreciate if you it takes 5 minutes, it's 3 questions, it just goes very fast. But if you indicate that they should be funding health services, they should be funding basic scientific projects, they should be continuing to fund innovative research so that we can continue our work to help you eventually. Thank you for attending. Be careful, don't slip and hurt yourself. You could have pain. The next public forum will be on April 16th on the Wednesday evening in the springtime.